everyone. Happy evening. A very good evening. I hope and I believe all of you are doing well. Before we start with this class, a quick nod whether the audio visual is good. Hi, so I hope I'm audible and visible, everyone. Yes, thank you so much, Avinash, and everyone here. This is a quick revision, of course, not everything, but the most important topics that we feel that would appear in your exam. So, this is basically ultimate revision, and I have been taking the revision classes, especially the last minute revision crash course for FMG, since last 1 week. So 3rd of December we have started. It's basically on the Unacademy platform. This is a very short session, Dr. Fiti. So I'm not going to, give you that a lot of information overload. It's just short session to break the monotony in your day and to give you that break, but a productive break so that you study with me. है ना? So absolutely. So this is a session where like इसको देखा तो FMG जिंगा लाला हो जाएगा. That is how it is. And not only this session, I would ask all the FMG aspirants to watch all the sessions that I've taken on the Unacademy platform as well. If you watch them, you'll get a lot of questions that you'll be able to answer. The upcoming 2 days, like this is till 10th, rather I'm taking it to 11th as well. So tomorrow 10th of December at 10 a.m. So 10 at 10, it's gonna be Super 10, where we are going to revise all the important images. Okay, all the important images combined of the various subjects, and if need be and if there's a lot of requests, then we'll take a part 2 as well for that. So we'll have radiological images for sure, anatomy, dermatology, ENT, ophthalm, like mixed bag images is what we will have. Okay, so no, it's not a complete a non-stop session. It's a very very short session, as I said, just to give you that confidence, to give you that boost that you know everything, you remember everything. So do not go into that stressed and anxious state कि सब भूल जा रहे, नहीं याद आ रहा है. Okay, so images is what we are going to do tomorrow 10 a.m. So I have not included any images in this session. And then on 11th, like the penultimate day for your exam, so 11th December 10 a.m., I'll tell you the ultimate exam hall strategy and the secret tips, basically the cheat codes on how you should be answering the MCQs, how you can get the answers right even if you don't know the topic. What are those few tricks? Because you know that in FMG exam even 1 mark counts, right? 150 here or 150 there, it makes a hell lot of difference. So even one question, if you get right by those cheat codes, that's a huge thing. And I'm pretty sure that with those cheat codes you'll get not only one but many questions right. So make sure that all of you attend these sessions at 10 a.m. The links I'll be putting in the description also, in the comments also, and in the Telegram group as well, which is Dr. Nikita's Radsynapse. So this is the group, the link t.me Dr. Nikita. Okay, so 2 sessions tomorrow and day after 10 a.m. on the Unacademy app. These are free live classes, so all of you can attend these classes. You don't need any subscription. Just that if asked for a code while attending the class, registering for the class, you can use the code Dr. Nikita while registering for the class. Okay, so that was an important update that I wanted to tell all of you. Okay, feeling anxious, absolutely I can feel what you must be going through, guys. The students who are appearing for exam on Sunday, everybody feels that. Whatever exams I have given in my life, there has never been one exam where I have not felt stressed or anxious. And I know that if I give any other exams in the future also, even at the age of 60, I am going to be anxious at the same level. So no matter how much we grow in the numbers, that is the age, but wo jo anxiety hota before the exam, that is always going to be there. And but after the exam, then we realize कि फालतू में tension ले रहे थे, फालतू में we were getting stressed, इतना कुछ था नहीं. And I'm sure that all of you will get that feeling after the exam, and I'll be waiting to hear from all of you. So all the very best, everyone. Do not miss on these. We are still meeting 2 more days, tomorrow and day after. Especially the exam hall strategy. तो जो भी final boost चाहिए, motivation चाहिए, pacify करना है, all that I'll be doing there. Okay, all that I'll be doing there. Okay. Toxicology, easy because of me. Okay, I thought, okay, thank you so much for those kind words, Deepak. Thank you so much. Thank you so much. It's me. Okay, so that is what my whole aim is, to simplify the difficult topics, because जो difficult दिखता है actually वो इतना difficult है नहीं. ठीक है? So these are the sessions that I was talking, exam hall strategy, and the most important images we are going to do binge revision. There are a lot of images, radiology images that we see in the exam. So without any further delay, let's start with the class. First thing, with the murmurs, the dynamic auscultation for the murmurs. Okay, the dynamic auscultation for the murmurs. Let me just close this. Okay. So murmurs का हमने images जो है वो discuss किया था. Tomorrow we'll do a quick revision as well, where we discussed how to decide whether it is a systolic murmur or a diastolic murmur. Just remember a quick point here, that diastole starts with S2, a very, very important point. Diastole start with S2, that is between S2 and S1 we have the diastole. So if you get an image of a murmur, which was there in the last to last FMGE exam, if it is between S2 and S1, it's a diastolic murmur. If it is between S1 and S2, it's a systolic murmur. After that, the next point, like auscultation may, the most important to be remembered, the only two murmurs which increase with Valsalva, which are the only two murmurs which increase with Valsalva maneuver. Remember, it is HOCM and mitral valve prolapse. Okay, HOCM and mitral valve prolapse. What are the other maneuvers which increase the murmurs of HOCM and mitral valve prolapse? Remember, the mnemonic there is VAST. Okay, the mnemonic there is VAST. So what do we remember with VAST is Valsalva, amyl nitrite. Okay, Valsalva, amyl nitrite, and ST stands for standing. This is something which is very, very important. So standing में ये murmurs increase होते हैं HOCM के और mitral valve prolapse के. Okay, very, very important to remember. And please do not forget, for mitral valve prolapse, what is the key word that you should be identifying? There is mid-systolic click. Okay, there's a mid-systolic click. So between S1 and S2, systole, mid-systolic click, and then there is a late systolic murmur. There's a mid-systolic click with a late systolic murmur, and it is associated with Marfan's. Okay, it is associated with Marfan's. So remember, Valsalva standing basically decrease in preload, increases the murmur of MVP and HOCM. Okay, it increases the murmur of MVP and HOCM, and also amyl nitrite. Okay, and also amyl nitrite. Next points, a very, very quick revision of the vegetations. This we had seen in the last class, but let us quickly revise. Which are those vegetations which are large and they extend onto chordae tendineae? Which are the vegetations which are large and extend to chordae tendineae? Is it rheumatic? Is it Liebman Sachs? It is infective endocarditis. Which one is that? Just a second. I'm not able to see the comments. Give me a minute. All right. Yes. So remember, it is infective endocarditis. Easy to remember. Infection tends to spread everywhere. So even the infective vegetations, they tend to spread to the chordae tendineae. So they are large, they are friable, and that is why we see emboli features in infective endocarditis. You have Roth spots, Osler's nodes, Janeway's lesions, right? All of those are there. And the criteria used for infective endocarditis is Duke's criteria. Okay, it is Duke's criteria that is used for infective endocarditis. The rheumatic vegetations are small warty vegetations along the line of closure. Which is that vegetation which appears on the bilateral, both sides of the valve ka surface? Remember, bilateral BIL is LIB, that is Liebman Sachs endocarditis, that is LSE. And LSE, Liebman Sachs endocarditis, is seen in SLE. Okay, it is seen in SLE. Very, very important. Okay. So look at the vegetations here. Large going to the chordae tendineae. This is infective endocarditis. On both sides, bilateral is Liebman Sachs, and it is seen in SLE. Rheumatic is small warty along the lines of closure. Okay. Now, brainstem syndromes. I think one of you had asked for brainstem syndromes, Amir or someone on an academy platform. I hope you are there. So, a quick revision of the brainstem syndromes. Okay. Just again focusing on the important points. Okay. Focusing on the important points. So, when you get third cranial nerve palsy, where will you localize that brainstem syndrome? Midbrain, pons, or medulla? Third nerve is midbrain, right? It is from the midbrain, so it is midbrain syndrome. When you get third nerve palsy along with hemiplegia, okay, along with hemiplegia, what brainstem syndrome is it? Is it Benedict's, North-Nagel, Claude's, Weber's? What brainstem syndrome it is? Very, very important. What brainstem syndrome has a third nerve palsy with hemiplegia? The trick to remember here is remember weakness. Okay, hemiplegia means weakness. That is WE. That is Weber's syndrome. Okay, that is Weber's syndrome. Very, very important. What do we have in Benedict's syndrome? Why this is not Benedict's? Because Benedict's has tremors. Okay, third nerve palsy with tremors. You can remember Benedict's as bobbing head. Okay, there is bobbing head. That means the abnormal movements. That is tremors because it involves the red nucleus. Because it involves the red nucleus. Which brainstem syndrome has third nerve along with superior cerebellar peduncle? Superior cerebellar peduncle. Remember superior matlab upper, the direction that we have upper ki taraf, that is north direction. Okay, that is north. So that is North-Nagel syndrome. Okay, that is North-Nagel syndrome. And then you have finally in the midbrain the Claude's syndrome. Remember Claude's is combination of, it is combination of two, that is Benedict's and North-Nagel. So B and C is what forms Claude's. So look at the table here. So when you have third nerve, okay, everywhere it is ipsilateral third nerve palsy. With contralateral hemiparesis weakness, that is Weber. With extrapyramidal, that is abnormal movements, Benedict's, bobbing head. Cerebellum, superior cerebellar peduncle, it is North-Nagel, and Claude's is a combination. Okay, Claude's is a combination. Next one, coming to the medullary syndromes. Okay, the medial medullary and the lateral medullary syndrome. Now, in the medial medullary versus the lateral medullary syndrome, we discussed in our today's neurology class as well at 5 p.m. So, in the medulla, what are the cranial nerves that arise from the medulla? 9, 10, 11, 12. Right? Easy way to remember cranial nerves. 12 जो cranial nerves है, divide into 3. That is 1 to 4, 3 parts. 5 to 8 and 9 to 12. So upper 4, middle 4 and lower 4, right? Upper 4, middle 4 and lower 4. So these are respectively from midbrain, pons and medulla. That means above the pons, in the pons and below the pons. जो 3 और 4 है वो midbrain में से है, olfactory optic ऊपर है, pons के ऊपर. Now the cranial nerves which arise from the medial compartment, the paramedian compartment. Remember those are the ones जिसके टेबल में 12 आता है. So 3, 4, 6, 12. Okay, 3, 4, 6, 12. 3 4s are 12, 4 3s are 12, 6 2s are 12, 12 1s are 12. So these are involved in the medial brainstem syndromes. So similarly, cranial nerve 12 will be involved in medial medullary syndrome or lateral medullary syndrome. It will be affected in the medial medullary syndrome. The rest 9, 10, 11 will go in the lateral medullary syndrome. So remember this very, very important point that 12th cranial nerve is not affected. It is not affected in lateral medullary syndrome, which is also called as Wallenberg syndrome. Okay, remember Wallenberg is lateral medullary syndrome due to vertebral artery or its branch, that is pica. Okay, vertebral artery or its branch, pica, we get the lateral medullary syndrome. So remember, there is no 12th cranial nerve palsy. And very important question, if there is right 12th cranial nerve palsy, where will the tongue deviate? To which side the tongue deviates? If you protrude the tongue deviates to which side? This has been a recent question asked in the exam. Okay, what will be the answer for this? So if it is right, a hypoglossal palsy, right side का palsy हुआ, the on protrusion, the tongue will deviate to right side or the tongue will deviate to left side. So Dr. Grace, remember it is ipsilateral side, that is right side itself. Okay. The mnemonic, the trick to remember the tongue licks the wound. Okay. जिस side में wound है, right side का palsy हुआ, right side में wound है मतलब the tongue licks the wound. That means it goes to the same side. That is how you'll remember forever. That tongue is ipsilateral deviation. Okay. It is ipsilateral deviation. So look at this one, medial medullary, that is degerin. There is tongue paralysis, same side, because medial is 12th. Lateral medullary, we will not have the 12th cranial nerve palsy. The trigeminal sensory will be going, so there will be loss of pain and temperature of the body and on the face. Not going into the details of that. Okay, I'm not going into the details of that. Okay. Now going to the next one, very, very important, parathyroid, vitamin D and calcitonin. Basically your calcium phosphorus regulation. Okay, the calcium phosphorus regulation, very, very important. Vitamin D, calcitonin, and what do we have next? Then we have parathyroid hormone. Now, easy tricks to remember here is that remember that vitamin D, we know that vitamin D is very, very important for calcium. So it is the one which increases the calcium, it increases the phosphorus as well. So both increases. Calcitonin is exactly opposite of vitamin D, it decreases the both. PTH is the one which has opposite. PTH is P, it has opposite effects. It increases the calcium but decreases the phosphorus. Very, very important point to remember. Remember, PTH increases calcium, decreases the phosphate. The trick to remember this is, remember that parathyroid catches calcium and it pushes away the phosphorus, right? It pushes away the phosphorus. So catches calcium means increases the calcium and decreases the phosphate. These are the most important points to be remembered. So whether this class will be like somewhere till 12, 10, 20, 25, maybe 25 minutes or so, whatever we can revise, we'll do it. We'll continue along with the images tomorrow morning 10 a.m. on the Unacademy app. Okay. So remember these very, very important points. So whenever you see that calcium बढ़ रहा है लेकिन phosphate is changing. Okay, what is happening to the phosphate is opposite. Remember, it is parathyroid का effect. Okay, it is parathyroid का effect. ठीक है. So what will you see in primary hyperparathyroidism? What is secondary hyperparathyroidism? Primary matlab the cause is in the parathyroid itself. So there is primary increase in parathyroid. So calcium increases, phosphorus decreases. Secondary means parathyroid खुद से बड़ा हुआ नहीं है. There is a stimulus for that. What stimulates parathyroid is decrease in calcium. So in secondary, there would be decrease in calcium which stimulates parathyroid. Then that parathyroid tries to normalize the calcium. And what will parathyroid do with the secondary one? आपका increased phosphate होता है secondary में because the most common cause is renal failure. So look at the secondary one. The phosphate is high or normal while the calcium is low. So it is basically opposite of primary. Okay, it is basically opposite of primary. And in tertiary, everything is high. Tertiary is not very important. Okay. Based on the same lines, some of the important bone disorders which are very, very frequently asked in your exam. कि osteoporosis में क्या होता है, Paget's में क्या होता है, multiple myeloma, renal failure and primary hyperparathyroidism. These are the most important that you should know before the exam. Osteoporosis, remember the biochemistry is entirely normal. Calcium normal, phosphate normal, alkaline phosphatase, everything is normal in osteoporosis. In Paget's, the only thing which is increased, it is alkaline phosphatase. There is new bone formation. Alkaline phosphatase is a marker. So alkaline phosphatase is very high. The rest of the two are normal. Exactly opposite happens in multiple myeloma. It is only alkaline phosphatase which is normal. The rest calcium phosphate are high. क्योंकि multiple myeloma में क्या होता है? In multiple myeloma, there are lytic lesions in the bone. These are the lytic lesions. Calcium phosphorus comes out into the blood. Calcium phosphorus is high. There is no new bone formation. That is why alkaline phosphatase is normal. Remember, in multiple myeloma. Very, very important. Okay, that's very important to remember. Next one, hyperparathyroid. We already said it catches calcium. So high calcium pushes away phosphate. So phosphorus will be low. Renal failure, it's the opposite. Secondary वाला उसमें कैल्शियम लो होता है क्योंकि विटामिन डी नहीं बन रहा है किडनी में. Phosphorus is not going out of the body, so the phosphorus is high. Remember these very, very important points. Okay, remember these very, very important points. Subhash, regarding the YouTube members only videos are not available now. I have been taking those classes on the Unacademy platform, predominantly on the Plus and few in the special free live classes also. Okay. Okay, now quickly revising the various vasculitis, the most important features that you should be knowing because vasculitis comes very, very frequently in the exam. What is the key point for temporal arteritis? What is the key point for temporal arteritis that helps you diagnose a case of temporal arteritis? Yes? I hope I'm audible and visible. I'm not able to see the live stream here. Just a second. Right. Temporal arteritis. Absolutely. So you can get an image-based question as well कि जहाँ पे आपको ऐसे temporal artery दी गई होगी, right, at the temple. And very, very important, do not forget to look for jaw claudication. Claudication मतलब pain when the muscles are used. So while chewing, there is pain. Jaw claudication is a very, very important feature. And generally, it's an elderly patient, elderly male presenting with the symptoms. Jaw claudication is very, very important. It is also called giant cell arteritis. So we see giant cells on biopsy. The treatment to be given is steroids even before biopsy is done because it can cause blindness also. Okay, it can cause ischemic optic neuritis. So इसीलिए steroids देना चाहिए. Okay, so more than 40-year-olds, there would be giant cells. Takayasu arthritis is the one which is also called as very, very important pulseless disease. Takayasu is your pulseless. That means it affects the main vessel, that is the aorta. So it is also large vessel vasculitis. Aortic arch can be affected. So remember, pulseless disease, you don't feel the pulse. That is an important feature. Polyarteritis nodosa, as the term says, polyarteries. Nodosa मतलब याद रखना कि arteries में nodules के जैसे aneurysm है. So there are multiple aneurysms that we see, especially in the renal, the visceral arteries under intrarenal वाले में. So remember, it is small, medium sized, typically involving renal arteries. What artery is spared in polyarteritis nodosa? Remember, it is pulmonary artery not involved. So it spares pulmonary vessels and it is associated with hepatitis B. Microscopic polyangiitis, not very important. Churg-Strauss syndrome, there will be a history of eosinophils increased and it is associated with asthma. That is Churg-Strauss syndrome. And what do we have in Wegener's granulomatosis? What do we have in Wegener's? Very, very important. Remember, it is C ANCA positive. Okay, it is C ANCA positive. You have upper respiratory tract. There can be sinusitis, otitis media, plus the lower respiratory tract which is affected, and the kidney can also be affected. Okay, upper and lower respiratory tract both are affected, and the kidneys. Okay, so vasculitis, these are the very, very important features that we should be knowing. Now going to this one, very important images. Look at this image and look at this image. The most important, frequently asked, the urine crystals. Okay, the urine crystals. What do we see here? So these crystals which we see here, the hexagonal shape. Hexagon matlab 6 sides. So remember 6 is like 16. This is 16, that is basically cystine. Okay, so cystine has 6 wala, that is hexagonal shape. A stone which is very, very resistant to lithotripsy. This is not true white, this is cystine. This is the one which is dumbbell shape. This is dumbbell shape. Now, no offense to any Mona here, but we remember this as that Mona is dumb. Mona matlab monohydrate. What monohydrate? Calcium oxalate monohydrate. So remember, Mona is dumb. The dumbbell shape is calcium oxalate monohydrate. And remember that this is not di Ashwani, this is mono. Okay, this is mono. और जो हमारा किसने बोला कि ट्रू व्हाइट स्टोन, ट्रू व्हाइट का क्या शेप होता है? White. Remember, true white is white. Where do we wear white color dress? When we go to the funeral. That is coffin lid. Okay, associated white with the coffin lid. You go to the funeral, see the coffin lid. So true white has coffin lid appearance. Okay, that is coffin lid. And which is the organism very, very commonly associated with staghorn calculus? Which infection associated with staghorn calculus? That is Proteus. Okay, that is Proteus is commonly associated because it is urease positive. Okay, it is urease positive. Staghorn calculus, common triple phosphate. The true white triple phosphate that forms the staghorn. Okay, image based radiological image can come in the exam. Okay, all right. Now look at this one. Identify the investigation. This is a DSA image. DSA, digital subtraction angiography. Look at the beaded appearance of the vessel. Remember, this is fibromuscular dysplasia, which has the beaded appearance. It can lead to renal artery stenosis. So it presents with hypertension in a young patient, predominantly female. Okay, it is female more than male. So fibromuscular dysplasia, beaded appearance of the vessel, very, very important. Now, this is your previous FMG question. Deepak, thank you so much for that. But that is what I love to do actually, making easy tricks and mnemonics. But what do you think is the answer to this and what is the image showing? Tariq, tree bark is syphilitic aortitis. If you are meaning to say tree bark, it is syphilitic. Yes, constrictive pericarditis. Even if you cannot identify the image, the question mentions rapid X and Y descent. That means both are rapid. That is constrictive pericarditis. Remember the JVP in constrictive pericarditis, very, very important. It is M pattern. Okay, it is M pattern. That means the X descent is also prominent. The Y descent is also prominent. And what do we see in constrictive pericarditis? It is calcific constrictive pericarditis. So there's calcification along the pericardium. Okay, the calcification along the pericardium. What is the JVP in cardiac tamponade with X descent and Y descent? What do we see in JVP in cardiac tamponade? Neeraj, again a correction there. Remember, it's egg in cup in constrictive pericarditis. Egg on string is in transposition. Okay? Cardiac tamponade, you basically remember tax. That is, tamponade has accentuated or aggravated X descent. The Y descent is absent. Okay, the Y descent is absent. Look at the image here. Look at the normal JVP. You have the X descent, you have the Y descent. This is the A wave. Okay, tamponade has X descent which is there, but the Y descent which was there, that is absent. So remember, absent Y descent. Tamponade has Beck's triad. Okay, it has Beck's triad. Constrictive pericarditis is both X and Y prominent. Okay, both are prominent. M pattern that we see here, right? This is the M pattern that we see here. So this is constrictive pericarditis. Next one, look at this one. Okay, what do you think is the answer to this? 47-year-old female with joint pains, very important, difficulty in swallowing dry food, gritting sensation below the eyes. She has normocytic normochromic anemia, ESR in increase, ANA positive, and it is anti-Rho positive. Okay, this is anti-Rho positive. What do you think is the diagnosis here? Anti-Rho antibodies are seen with. Let us have a quick review of the antibodies. Very, very important. Anti-Rho, anti-La. Okay, anti-Rho, anti-La. Remember, Rho is, what is Rho? Is rhyming with joke. Okay, so that is Jogrens. Okay, that is Jogrens, where we see anti-Rho and anti-La. Then you have in SLE, what are the antibodies? Most sensitive screening करने के लिए ANA. फिर हम करते हैं dsDNA to look for the activity, and you have anti-Smith, which is very specific. Then you have scleroderma. What is the antibody in scleroderma? Remember, scleroderma is SCL, so it is anti-SCL70, which is basically topoisomerase. What do we have in limited sclerosis? That is the CREST syndrome. What is the antibody in CREST? Remember C4C. It is anti-centromere antibody. Okay, C4C, anti-centromere. What antibody do we have in drug-induced SLE? What antibody do we have in drug-induced SLE? So in drug-induced, we ask for history. History, right? So remember, history lenge drug ka. So it is anti-histone antibody. Okay, it is anti-histone antibody. Which drugs can cause SLE? Which drugs can cause SLE? Yes. Remember SHIP. Okay, SHIP. That is sulfonamides, hydralazine, INH, the AKT drug INH, and procanamide. Okay, the procanamide. So that is drug-induced SLE. Next one, anti-endomysial antibodies कहाँ होती है? Anti-endomysial antibodies. That is seen with celiac sprue. Okay, that is seen with celiac sprue. Celiac sprue, you will have the history of wheat allergy. It is associated with which skin condition? Very, very important. Which skin condition? Dermatitis herpetiformis. Okay, dermatitis herpetiformis. And in that, what is the history with dermatitis herpetiformis? Extensor surface pe there is very itchy papules. Okay, so on the extensor surface, elbow pe, knee pe, there will be papules which are very itchy. And what is the drug that we give in dermatitis herpetiformis? It is dapsone. Okay, the drug to be given is dapsone. Very, very frequently asked question. Okay, very, very important. What is the HLA associated with celiac sprue? Wheat DQ. That is DQ. Remember, wheat DQ celiac sprue mein? That is DQ2. Okay, that is DQ2. Next one, going to the next question, that is, yes, very good, Aruna, that is IgA deposits, the granular IgA deposits, papilla mein, dermis ke papilla mein is what we see, the granular deposits, okay, dermat mein. Ye ho gayi wo bodies. Tell me, where do you see anti-mitochondrial antibodies? Anti-mitochondrial antibodies are seen in primary biliary cirrhosis. Okay, primary biliary cirrhosis, where you generally have a female patient with a lot of itching because obstructive jaundice causes pruritus. Okay, that's a very important history there. After that, yes, C अंक का हमने already दे दिया. C अंक का, remember, is vaginous granulomatosis. Okay, C अंक का is vaginous granulomatosis. Where do we have anti-U1 wala antibodies? U1 RNP antibodies. Remember, U matlab universal, that is mixed connective tissue disease. Okay, it is mixed connective tissue disease. What is the antibody in dermatomyositis? What is the antibody in dermatomyositis? Dermatomyositis, remember, it is anti-Jo. Okay, it is anti-Jo antibodies, and the common cancer that it is associated with is ovarian cancer. Very, very important. So what should you monitor the tumor marker for ovarian? CA125. Okay, CA125 should be monitored. Okay, CA 125. उसके बाद द नेक्स्ट वन, हाँ उसमें MI भी रहता है, डर्मेटाइटिस herpetiformis में एंटीजो और एंटी MI. उसके बाद what were we discussing? So this question where we have anti-Rho is, remember Jo, that is Sjogren's. You get conjunctivitis sicca, the dry eyes, the dry mouth. These are very, very frequently seen in Sjogren's. Okay, these are very frequently seen. Rheumatoid arthritis, we have rheumatoid factor. Most specific is anti-CCP. Okay, it is anti-CCP. Okay. Next one, look at this image. Image, very, very classical. We'll see tomorrow as well. The starry sky appearance, that is Burkitt's lymphoma. Chromosome 8, gene is c-MYC. You get 814 to 822 translocation. The even number wala associated with Epstein-Barr virus. There can be jaw swelling. Like we see here, child with jaw swelling, lymph nodes enlarged. This is Burkitt's lymphoma. Starry sky appearance. Okay, remember the starry sky appearance. Next one, this is very, very quick review of the important points. I think the last 5 minutes of the class. So hepatitis B serology is very, very important. Remember, the only serological marker present during window period in hepatitis B is anti-HBC. Okay, what is the sequence of the serology in hepatitis B? Remember, SEC-S. Okay, that's a palindrome. ऐसे पढ़ो या ऐसे पढ़ो, it is SEC-S. These are S and E are the antigens. From here starts the antibody. So we have HBS antigen, HBE antigen, anti-HBC, anti-HBE, and the last to come in the hepatitis B serology is anti-HBS. So that is the one which tells you that the patient is recovering. That is the last to come. And remember that, okay, IgM, of course, it is IgM, but against anti-HBC, right? The IgM is a type of immunoglobulin. IgM, IgG, against which antigen? Basically, it is against HBC. Okay, so is that clear? Tariq, is that clear? PDF of the PPT which I am sharing, I'll share on the Telegram group after the class. Okay, I'll share on the Telegram group. What is the only serological marker in a patient who is immunized, who has received a hepatitis B vaccine? It is only antibody is what the patient should have against what is used for vaccine? HBS. So anti-HBS only is positive. In the window period, it is anti-HBS नहीं, it is anti-HBC. एक बार इन्फेक्शन हुआ तो anti-HBC हमेशा प्रेजेंट रहता है. अक्यूट वाला है तो IgM, chronic वाला है तो IgG. Okay, chronic वाला है तो IgG. And what marker indicates the infectivity or the replication in hepatitis B? Very, very important. Again, what marker indicates replication or the infectivity? Remember, replication is E, it is HBE antigen. If HBE antigen not there in the option, go with HBV DNA. It's a DNA virus. Okay, that indicates high infectivity and high replication. Tariq, it is not anti-HBE. It is not the antibody which will tell you replication. It is the antigen which is multiplying. So remember, it is HBE antigen and HBV DNA. Okay, these are the important points. Rot spots, basically fundus में infective endocarditis. Cannon A waves. Okay, the huge A waves in JVP represent complete heart block. Where do we have absent A wave in JVP? A wave is atrial contraction, atrium not contracting. So that is atrial fibrillation. Okay, atrial fibrillation. Very important, we have discussed in our medicine revision classes on Unacademy recently. Hyperkalemia is a feature of type 4 renal tubular acidosis. Okay, type 4 renal tubular acidosis. Cancer causing polycythemia, RCC. Erythropoietin आएगा, polycythemia होगा. Nodular glomerulosclerosis, remember, is diabetic. The KW lesions that we see. Pure red cell aplasia is associated with thymoma. Thymoma is associated with myasthenia gravis. A patient of DVT, post-surgery immobilization, Homan sign positive calf pain. What is the investigation that you will do? Very, very important. Duplex ultrasound, that is a Doppler. Okay. Bilateral upper limb pulseless, we already said pulseless is Takayasu's, large vessel vasculitis. Remember, in renal tubular acidosis, it's a normal anion gap. Anion gap is not increased. Metabolic alkalosis, is it hypokalemia or hyperkalemia? Remember, all K loss. Alkalosis is all K loss. That means it is hypokalemia. Very, very important. What do we see in congenital hypertrophic pyloric stenosis? Is it acidosis or alkalosis? Vomiting is happening, stomach acid going out. So alkali in the body. Remember, it is alkalosis. All the electrolytes going out. There is hypochloremia, hypokalemia. But remember, there is paradoxical aciduria. Okay, there is paradoxical aciduria. What is the condition which has granulomas and it has hypercalcemia? Sarcoidosis. Very important. Remember, it has bilateral hilar lymph nodes. Bilateral hilar lymph nodes with hypercalcemia. Granuloma. What granuloma it is? Remember, non-caseating granuloma. Okay, non-caseating granuloma. What enzyme level is increased? The ACE levels are increased in sarcoidosis. Okay? Which disease causes orchitis as a complication? Remember, mumps. Okay, mumps causes orchitis. Very, very important. नीरज, AML, ALL, CML, CLL क्या याद रखना है? ठीक है, मुझे I'll do it in the tomorrow's 10 a.m. class. Okay, so I'll get that table and I'll do that. ठीक है. ठीक है, clear with everyone. And going to this one. Okay, going to this one. Conn syndrome. What will you see in Conn's? Remember, Conn's is basically hyperaldosteronism. Hyperaldosteronism. Remember, aldosterone is AL. It causes alkalosis. All K loss. So there will be hypokalemia. Pheochromocytoma, very, very important. You'll get a history of intermittent headache, flushing, palpitation, sweating. All of that is pheochromocytoma. Screening test, you look for urinary catecholamine fraction, metanephrine and VMA is what we check for. Hinault-Schönlein purpura. You'll get a patient with purpura. It might be a child. GI bleeding bhi hoga, joint pains hoga. All of that would be the history. And remember, Hinault-Schönlein is IgA deposition. Okay, it is IgA deposition. Hemophilia ka history. Hemophilia A, X-linked recessive. So you'll get a history that maternal uncle has a disease. In the patient, we see the bleeding into the joint. Remember, hemophilia is heme arthrosis. Not in the skin, but in the joints is where we see the bleeding. That is hemophilia. What cancer, thyroid cancer is present in MEN syndrome? MEN2. It is medullary thyroid cancer. It is medullary. What is the tumor marker for medullary? It is calcitonin because it comes from the parafollicular C cells. From which germ layer parafollicular C cells coming? Neural crest cell. Okay, neural crest cell. Drug of choice for CML, remember, is imatinib. Okay, tyrosine kinase, imatinib. Very, very important. CML has Philadelphia chromosome, translocation 922. Emphysema will have respiratory acidosis because there is CO2 retention. Obstructive pathology, CO2 retention, acidosis. Pneumatocoel is what pneumonia? Staphylococcal. Very, very important. Anti-endomysial, celiac disease. Alpha-1 antitrypsin. Remember, it affects the lungs. It is emphysema, pan-acinar emphysema, and also liver. What is the history in liver disease? It is PAS positive diastase resistant. PAS positive diastase resistant. Wilson's disease, very, very important. Liver affected, cirrhosis is there, psychiatric manifestations, abnormal movements. So Wilson's, remember, copper deposition in the tissues. Urinary copper is increased, ceruloplasmin is decreased. It is chromosome 13, autosomal recessive, ATP7B. Remember, Wilson, sun matlab beta. So it is ATP7B. Drug of choice for trigeminal neuralgia, sudden shocking pain in the face, that is carbamazepine. Okay, remember, that is carbamazepine. Very, very important. Anti-dsDNA, Dr. Grace, is for SLE. specifically to look for the activity of SLE, whether it's active or not active. वो सब करते हैं, ठीक है, NTDS DNA करते हैं. So yes, guys, that was about the today's rapid revision. There's a lot to be covered. Feels like it is my exam in the next 2 days. So we are going to do a lot of it. Tomorrow 10 a.m. we will have the binge revision of the important images for FMG, including radiology, microbiology, all the other important images, anatomy, sub mixed bag hoga tomorrow 10 a.m. As I mentioned, do not worry, it's a free class, so all of you can attend. It's on the Unacademy app. If asked for the code, use code Dr. Nikita. I'll share the link in the comments, in the description of this video, and on Telegram group also. You can stay connected with me there. And finally, the most important session before your exam, one day before the exam, as I always used to feel, there should be someone who gives me that confidence. You know, you remember everything, you will do well. These are the tricks that you should use in the exam hall. These are the mistakes that you should not do in the exam hall. All of this I'll be talking about on 11th, again 10 a.m. morning, just one day before the exam to give you that extra push. Okay. So that was for today's session. I hope this helps you for your exam. See you tomorrow and day after again at 10 a.m. on the Unacademy app. And do not worry, guys, you all are in a good shape and you'll definitely do very well. All the very best, and I'll be waiting to hear from each one of you. Thank you so much and goodbye. Take care. Keep studying.